you sticky? And then what? And then what? Okay, good. Yeah. Good. Ear clips. Okay, good. The cute correct answer is remove, remeasure, reinsert. Isn't that cute? Okay. Remove, remeasure, reinsert. So in the morning I said all your answers should start with re. Remove, remeasure, reinsert. Very good. Okay, when a patient has an endotracheal tube, the nurse would never, I wouldn't say never, but the nurse most likely is not going to insert an endotracheal tube. That's going to be the physician, maybe a respiratory therapist. But there are certain things a nurse can do to assist with putting in an endotracheal tube and or maintaining it. What would those things be? What would a nurse be responsible for when a patient's having an endotracheal tube placed or catheter placed? Good. They're kind of lame, but it's fine. The desk there. I got new boards and new markers and new erasers. Okay, a lot of people put suctioning and stabilizing. That's good, but I'm kind of bored. The real things I was looking for would be go and gather equipment, auscultating lung sounds. Okay, the doctor probably doesn't even have a stethoscope. Let's be real. So once they place the tube, it's going to be your responsibility to listen and auscultate lung sounds. If the doctor has placed the tube too far, it's probably ended up where? You just tell me. In the lung. And which lung?
Right.
The right. Why? Because the right bronchus is wider, shorter, and straighter, the path of least resistance. And so if the tube has gone too far, it's going to be in the right bronchus. And how are you going to know that? What do you hear? Or what do you not hear?
Lung sound.
Where?
In the right.
You only hear lung sounds in the right.
Oh,
right?
You only hear it in the right.
Yeah, because that's the only place that's getting ventilated.
Oh,
Right? And so if you listen and you hear lung sounds on the right and nothing on the left, you know the tube is too far and the doctor's got to back it up. Okay, he's literally going to ask you to do that. Go ahead and check his lungs. You're going to listen. Oh, I only hear him on the right. Now I'm going to back the tube up. Okay, and that little video, I don't know if they played the video for you in the class, but it literally says this. And you'll talk about what the nurse is responsible for and stuff. The other thing I would say is, especially when the tube first goes in, that the nurse is primarily responsible for is the measurement. Okay, so they're gonna like have that little ET tape or whatever securing the tube, and the exit mark is gonna be important for you to know because the doctor is certainly not gonna add that LDA to Epic. That's gonna be you. Yes.
So if it's like, if you see like the number 23 or whatever, that would be what we need documented.
That's exactly right, okay? And so shift to shift, day to day, it should be at 22, right? No different than your NG tube. Like you should be making sure it's there. Because even when these patients are sedated, nobody wants a breathing tube in their mouth, okay? And so they're gonna wanna rip it out for sure. And so it's gonna be important that we check day to day, shift to shift to make sure it's at the right centimeter marking. Okay, that's good. Okay, a tracheostomy is a surgically created airway, and this is typically indicated when a patient has been on a mechanical ventilator for how long? Good, 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 good.
What is it, 2 weeks? 2 weeks. 20 minutes.
You're just right. Minutes?
No.
20 minutes?
No. I'm joking.
Now we're all staring at her, she's nervous.
I'm joking.
This is good.
No, it's still not
The
there.
correct answer is 21 days, okay? When a patient's been on a mechanical ventilator for 21 days, Then we talk about doing surgery to treat a tracheostomy. This is a big deal, you guys. This is a big deal. This is, we're gonna have to have all the family in the room. We're all gonna have to come to consensus on this, talk about the patient's quality of life, because once we do this, right, the patient can live a very long time like this, a very long time. And do we want that for this patient? Do we want them to live a long time with this artificial airway? Is that the best quality of life for them? I don't know. Every patient is different, right? Depends on their age and their other, comorbidities and things. But we don't just do this for fun, okay? This is like big deal. Meaning, if you ever see somebody who has a scar from a trach and they tell you I used to have a trach, they went through something. And that was a big decision, a big situation, and so we don't, do that lightly. Okay, with that being said, when a tracheostomy is placed, when is it most vulnerable? Risk for infection, risk for dislodgement. Good. Good. Good, good. You guys are doing real good with the numbers. I just hope it shows up on your math problems as well. Was that a good dig?
Yeah.
You guys are doing good. 7 days. First 7 days is the correct answer, and you guys are doing well with the number stuff. 21 days, 7 days, everybody got it right. Unless you put 20 minutes. Okay, now tell me, what is some equipment you want to have at the bedside for your patient with a tracheostomy? Should be thinking about that sim lab. What things do you want to have at the bedside when your patient has a tracheostomy? And if you write only 1 or 2 things, I'm going to be very bored. So there's 5 things on your PowerPoint slide.
I wrote 2
Now,
pages.
when you see how I spell arbitrable later,
Very good. You want to give me any numbers on those last 2? That was good. Good.
What kind of number do you want?
Whatever you picked in the
Did
lab.
everyone else put a number?
Yeah.
No, they
No.
didn't. They
Well,
didn't.
for one thing.
No, I
There's
like,
one
okay,
size
okay.
smaller.
That's good.
That's
You wanna give me a number on the last thing? That's good. You wanna give me a number on the last thing?
Okay. Oh, yeah, I can give you a number.
Okay, numbers, I'm into the numbers. Okay, that's good.
Forget the number.
Yeah.
Oh.
Oh, you picked up those laminated cards, remember? Yeah. All right, the correct answers are a trach of the same size and 1 size smaller, an obturator, which usually comes in the trach care kit, but if you were to obturator too, that's great. Suction catheter, specifically a 14 French. Suction system, remember we're gonna turn that up between 100 to 150. Functioning oxygen, remember we're gonna turn that up to 100, to 10 to 15. If you put normal saline, I think that's great too.
And cover.
And like some gauze
Gauzy cover.
gauze stuff is good too. Okay, cool. On the tracheostomy, there is a cuff. What is the purpose for inflating that cuff?
Not spelled, so.
For what?
Doesn't say.
No.
So,
What?
For the first, it's fine. I'll give you some more things. Good. Yes.
okay.
No. Good. 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 No. The correct answer is to prevent aspiration when the client is eating and to prevent air leaking around the tube when the patient is on a mechanical ventilator. Okay, because the only air that should be moving is inside the tube. The trach cuff does not hold the trach in place. It does not. In fact, think about it. If I just told you there's 2 indications for when you would inflate the cuff, when the patient's eating or when the patient's on a mechanical ventilator, does that mean if it's not inflated, we don't want to maintain it? No. Right? You know what I'm saying? So if your answer was to maintain it or keep it in place, well, what happens when we deflate it? It falls out? No. What holds it in place is the trach collar or the trach ties, which is why when you're changing those, especially if it's within the first 7 days, you need a buddy. You know, because if they cough and that thing launches out, you know, you're gonna be excited. Okay, so 2 indications: prevent aspiration when the patient's eating, prevent air leaking around the tube when they're on a mechanical ventilator. Does not hold the cuff in place, and if you like saw them in the lab, when you hook that little syringe up and inflate it, it's like a balloon. It'll get very, very firm the more you inflate it. And so if you overinflate the cuff, that's not good either. It can put a lot of pressure on the trachea. Yes.
No, I just wanted to make sure that I understood that it's the balloon at the kind of
Yes.
bottom of that.
Yes.
tube.
And so if you look at the trachs in the lab, they all have like a little, like, you know, tail hanging out.
Yeah.
And that's where you would hook the syringe up to inflate or deflate the cuff.
Oh, okay.
From my experience, my first job ever was on rehab, and most of my patients who had trachs didn't eat, and none of them were on mechanical ventilators. So I never messed with a cuff. It was always deflated because they weren't on a mechanical ventilator and they weren't eating. And so, you know, I did trach care and suctioning, all that stuff, but I didn't ever have to inflate or deflate the cuff. Maybe until they were starting to trial eating, you know, would we then inflate the cuff. Does that make sense? Okay.
And the difference between the mechanical ventilator and just like oxygen is that the mechanical ventilator actually breathes for them.
Yes.
Yeah.
Yes. It's a active oxygenation versus, you know, just
The
wearing
lungs are
oxygen as
still
is
working
passive.
when we like give them oxygen, but like they're still breathing on their own.
Right. Right.
We're just providing that extra oxygen.
Yes, you got it. Okay, let's talk about, okay, tell me some indications for suctioning. How do you know if your patient needs to be suctioned? Good. Good. What about the second thing? Good. Good.
Are you sure? Did you look on the-
Well, I was distracted because the old answer was still over
Yeah, I
there.
need it to be in.
Very good. Good. Some correct answers include restlessness, labored breathing, meaning increased respiratory rate, increased heart rate, decreased O2 stat, adventitious breath sounds like crackles or ronchi. I love you all, but if you wrote like junky or lung sounds, that's not what your test is going to say. You know, it's going to say ronchi, crackles.
That's the children's, and that's all they say is junkie.
Yeah,
Is that-
junkies, yeah, that was yeah.
It's fine. I am mad at you. Then there's, of course, cyanosis, restlessness, I think maybe I already said. Keep in mind late manifestations of your patient not getting enough oxygen due to too many secretions versus early. So if your patient's cyanotic,
That's like,
You're late.
you're late. You're late, you know what I'm saying? And if your patient's blue and you go in and you get out your stethoscope, I'm gonna wrap it around your neck, okay? Because hello, they're blue, their O2 sats in the toilet, their heart rate is now dropping, it's low, like they're ready to go be with Jesus, okay? So you better, you know, let's go. Let's suction them, let's get their airway back open.
have that.
Yeah, it's cute, very cute, okay? So as you're studying, be thinking about early manifestations of hypoxemia versus late. Okay,
Late
very-
is Brady and cyanosis, right?
Brady and cyanosis would be late, yeah,
That's what I'm saying.
yeah.
Restlessness is for like a really early.
That's an early sign.
Yeah. Increased heart rate, increased respiratory rate, right? That's gonna be the body's first reaction. Let me breathe faster, let me beat faster, maybe I'll get some oxygen circulating. No, you just gotta get your boogers sucked out. And that'll help you. Okay, good. Now, all of you guys for your psychometer skill are gonna be doing open suction, you know, so you gotta have your sterile hand and your non-sterile hand and all that stuff. But there is a system set up called closed suction technique. What is the benefit? There's two really, for the closed suction technique. That's where it's encased in that plastic sheath or wrapping.
I'm guessing on the second one. And it's what happens right now.
That's a good guess, that's what I'm looking for.
But the first one's right, right?
That's right.
Is my
good.
first one right?
Yeah.
What's the
That's
second one?
good.
It's nice and easy.
I can't remember the second one.
She can't tell you yet.
Oh, yeah.
Everyone's still writing.
The first one.
Okay, yeah, yeah.
That's what I got basically for the first one.
Those are good. Not what I was really thinking of, but they're good. No, I'll sing them. You guys know how to make shit up. That's why we don't give you fill in the blank questions, because I feel like,
He's okay.
is this right?
I'll
I mean, I don't know.
Like,
It's kind of right.
right,
It's
right?
kind of right. Okay, good. The correct answers are, it stays sterile. It maintains its own sterility. So if you put less risk for infection, or I wouldn't say you don't have to be sterile, because like it is sterile, but you don't have to worry about a sterile hand and non-sterile hand, right? It's all encased.
For us.
It's easier on you, and better for the patient. The main thing though is that the patient can continue to receive oxygen. So you mostly see closed suction technique on a patient who's on a mechanical ventilator. Again, my experience working on rehab, I never use closed suction, only open, because my patients were ventilated. And so I had to have my sterile hand and my non-sterile hand. And, you know, I was sucking all them boogers out, having a great time. Everybody hated it but me, I loved it.
Love what?
Sucking boogers out.
I feel like I like it.
I
don't
love
know
it.
why.
It's like, you know, when your kid's got like a stuffy nose
I
and you
love
finally
it.
get it all and you're like, don't you feel better? It's like the best. And they look at you and smile and you're like, yeah, you feel good now. And it's
Children,
because
the
of
other
me.
day, we were on TCC and one of our kids wasn't doing too hot and he had a plug and it shot out, got on guys.
Did you squirt some guppies in there? Some
I didn't do
saline?
anything, it's shot all over.
Yeah.
the
It's contraindicated in our textbooks, but in real life, we squirt saline down there and they'll launch a booger straight across the room. Yeah. I'm like, well, y'all better back up. Here it comes. But our textbooks say it's contraindicated.
So they can receive oxygen at the same time.
Mhm.
Okay.
Yep. Versus, you know, in your psychomotor, you gotta move it on and off and on and off and pre-oxygenate, take 2 to 3 deep breaths and all. You don't have to do any of that because they wouldn't be able to participate in that even if they could.
Can we, I'm sorry, can we add the multiple use? You don't have to change the,
Oh yeah, that's a good point. You don't have to like use a new catheter every time. That,
Yeah.
that can remain connected. Very good. When performing trach care, if you were cleaning like around the stoma, like the faceplate or any area around the stoma, what solution do you use to clean there? Good. Good.
I'm not gonna bring it.
You grabbed the wrong bottle and said I'm gonna grab that. Yes, yes. Yes.
You're thinking of
My brain fart. Saline, right?
The correct answer is normal saline. If you
Oh.
said sterile water, you're thinking about a chest tube. Okay,
Yes.
we use normal saline, one, because it's an isotonic solution, and number two, it's gonna lubricate the catheter, but not like shift any fluid or do anything weird like that when some of it isn't still in the patient.
Yeah.
The reason I'm emphasizing this though is because at Children's, and this could have been an EBV practice, but nobody probably picked it up, they use soap and water. They use soap and water. I don't know why they do that. I would love for someone to tell me, but that's not in your textbook anywhere. So certainly for testing purposes, it would be normal saline, but you know, that's just one
And
example.
they use
of-
Dasani instead of sterile water.
They never use sterile.
Really?
They
Dasani?
From the.
They use
water
ours from
machine
the
in a
thing.
Plastic cup.
Yes.
Oh, we had
The
little
same one patients get it
styrofoam
from.
cup.
I about died.
I know. I'm flushing with what?
Yeah. You know there's
For
nasties
the
in there.
feeding tube stuff?
Yes.
Yeah.
That I guess I could see a little bit because it's like your GI, but
I
like.
guess.
Okay, good. Now we're gonna move on to chest tubes, okay?
Okay.
Okay. All right. The sole purpose of a chest tube is to do what?
You better not say no.
Good. I mean, good enough. I got better words for it, but you're on the right track.
Well, my brain is out of words. You know how many assignments we just had to do in the last 3 days?
Can't think of how to word it.
But,
Yes. Yes.
what'd you say?
I'm writing way too much, I
I
know.
said ring and blink, what'd you say?
Negative pressure.
You're so smart.
It's fine. It's good. It's good.
Good.
It's good. Okay. if you wrote to draw fluid off or to remove air from the pleural, those are all true things, okay?
Not the main reason.
But in general, this is important, the purpose of a chest tube is to reestablish negative pressure, okay? Now, if the disruption in the negative pressure is air in the pleural space, well, air rises, and so they're gonna have a chest tube up towards the top of their lungs, and that's what we're gonna be removing is air, okay? If it's fluid, like blood or too much pleural fluid, then it's gonna be lower, because water sinks, and then that's the purpose of what we're gonna be removing. But whatever it is, air or fluid, I don't care either way, that should not be in the pleural space, because it's going to impede on the ability for the lung to expand. Right, the lung's not gonna have anywhere to go. Very good. When the chest tube is in place, what kind of dressing should be on there? Good. Good, good, good. Good, good. The correct answer is an occlusive dressing. Do you guys know what that means?
Yes.
Yeah.
Okay.
It's close on all sides.
Good. It's closed on all sides and nothing is moving or able to move through that dressing. So for the simulation experience, that was supposed to be an occlusive dressing, but the patient, his skin was not adhesible, okay? And so one day group, man, that guy was holding pressure on there for like 30 minutes. I was like, is he ever gonna come off the dressing? But I appreciate it, right? Because like, if we're being honest, that did not look like an occlusive dressing. So those that were excited about the dressing, I ain't even mad at you, right? But in real life, it should be an occlusive dressing. Adhere to the patient's skin. You should not be able to see up under there, right? It should be completely occlusive. So great. If the dressing is saturated and you need to change it, so now the dressing has come off temporarily, and you're visualizing the chest tube, if you see eyelet holes, what does that mean to you? Write it down. Good. 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 There are no words, it's just pictures. So I'm just winging it, guys. Okay. What do you got? Well, it's not an EP tube, but it's a chest tube. But you're right. If you can see the eyelet holes, that means the tube has come out some, okay? You should not be able to visualize those. Think about those. The holes are designed to drain the fluid and or air. And if they're on the outside of the body, not the inside of the body, what are they draining? Nothing. Okay, very good. Okay. I was just thinking of things I didn't ask the morning group, but too bad for them. Okay. All right, now let's get into the actual chest tube here. So this chest tube here in front of me has water in the suction chamber. Do you see it? Okay, and so this is a what kind of system? You can just say it out loud.
Wet.
It's wet. Okay. Wet has water in the suction chamber. If there was a cute little dial over here, it would be a dry system. Okay. Why do they do that? Because someone smarter came along and said, dang, people are all mixed up because there's water in the water seal and there's water in the suction. They don't know what the hell's going on. I want to make a dial instead of put water in the suction. Maybe they'll know what they're doing. And I appreciate that. But for your test, this is what you're going to see. Why? Because it's more complicated and I need to know that you understand what this is and what is happening in these three things. Okay? You will see this exact thing again. Okay, so take a good look at it. Okay, here we go. Starting over on this side, there is a long tube here. It's usually about 6 foot long that is connected to the patient's chest tube. There's like 3 total columns where this would fill. Write down for me what is the word I'm looking for?
Chamber.
What chamber? Thank you. What chamber is this? Good.
I don't have words today
Yes.
either.
Yes.
I'm gonna say,
Yes.
hold on.
Yes. Yes.
Yes.
Okay.
The correct answer is this is the collection chamber, the drainage chamber, the trap. okay? This is where the fluid goes, okay? And it fills up and it spills over and it fills up and it spills over. In fact, if you ever see one of these in real life, we document, you know, our eyes and nose once a shift, you'll see big gaps in measurements, and then all of a sudden they'll get smaller and smaller and smaller. Meaning when it's first placed from shift to shift, a lot of output, right? And then as the patient improves and the fluid comes off, now your measurements are less and less and less. And you'll be able to see these markings on the outside of this chest tube. We don't even replace it when this gets, as this fills, until it's full. Okay, so once all three of those columns are full, then you would get a new chest tube system. Okay? Yes.
Is it marked on this actual chest
Yes.
tube? I mean, it's probably also documented, like, but.
Yes. And so
kind
you
of
would just
on
put
that-
like, you would just put like a little hash mark, your initials, and I don't even think you put how much, just your initials and
Kind
the
of like
time.
a Foley bag has like that,
Yeah,
Okay.
yeah. Okay, so in the drainage or collection chamber, the first thing here, what would be some things that would be concerning to you if you saw in there that you would let the provider know? Good. Good. That's only one thing, so I'm a little bored, but it is good. That's good. I'm gonna give you a different number, but it's good. It's only one
Boring.
thing. It's only one thing, so I'm bored, but it's good. 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 The correct answers are more than 100 milliliters per hour, bright red blood, or blood clots. Okay? Very good. The morning group, like 5 people wrote no drainage. I'm like, well, that would be a
That's
good
good.
thing. You know, but it was just interesting. Okay, next up. Okay, so you notice I'm not talking about the letters, right? I haven't said anything about the letters. I'm not going to say anything about the letters because the letters change. Okay, and I know how you are. Oh, this is question number 44. Oh, it's A. Okay, you know letters. I know you know letters. But what I want to know is that you know where to look with your eyeballs, okay? And so there's going to be arrows or some sort of direction of what is this, just like you saw in the sim lab. There was no, what is A, what is B? It was a sticker saying right here, okay? So that's how we're going to do this. So all of this is the collection chamber. So if it's pointing here, collection chamber. If it's pointing here, collection chamber. If it's pointing up here, I mean, that's still going to the collection chamber, right? Okay. Next up, from here all the way up to here is the what? Write it down. Good. 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 Do me a favor, if you haven't already erased it, leave that on your board. No. Yes. Yes. Yes.
I'm not smaller then.
Yes. And keep it on.
Okay.
The correct answer is that is the water seal. Okay? That is the water seal. Keep your water seal on there. How many centimeters of water should be in the water seal? Good, good, good,
We are doing good with the numbers.
good, good, good. The correct answer is 2 centimeters of water, okay? And in fact, if you come over here and look, it literally says 2 centimeters. Now, to be honest, I kicked this earlier, and so the water is a little distributed, okay? But it's 2 centimeters of water. See it right there? Mm-hmm. Okay, it's a little above it because I spelled it. It was actually spelled to -20, but shh. Okay. All right. That's that. Okay. Keep it on everything on your board. What should happen in the water seal? What should you be looking for? Good. Good. No. Good. No. Get rid of that thing, keep that thing. No, get rid of that last thing. Mm-mm.
Me?
Yep.
We're the same thing, it's okay. So the first one's right?
Yes.
Okay.
Okay, the correct answer is titling. Okay, I need everyone to be with me right here, right now. Okay, this is very, very important. I don't care what anyone has said, what you see on a video, yada, yada, yada. What should be happening in the water seal is titling. Titling, rise and fall of the water like the
Can
ocean.
you spell title?
Tidal.
Okay.
ING. Okay? Titling in the water seal. This is what it looks like. Okay, so there's a little bead. Okay, the bead is resting on top of the water. And so when the patient breathes in and out, the bead is gonna rise and fall. The purpose of the bead is so you can see where the water is, because it's hard to see it without it, okay? So, patient's breathing in and out, and in and out. Do you see the rise and the fall? Okay, that is titling. That is what should happen in the water seal when the patient breathes in and out, okay? If there is no titling, that can mean two things. What are they? This is supposed to happen when the patient breathes in and out. No. Not what I'm looking for. Not what I'm looking for. No. No.
Can you say the question again?
If there is no titling, it can mean two things. What are they?
Yeah.
And it's not it.
The first thing is yes. No.
Are you ignoring me?
They stopped
First
breathing.
thing yes, second thing no.
Oh, that's what I put.
It's not it. Can you hold it up a little higher? First thing yes, second thing no. First thing is no, and the second thing is,
Draining is over.
no. Yes. The correct answer, this is important. The correct answer is negative pressure has been reestablished and the lung is expanded, or the tube is kinked. They're laying on it,
Duh.
it's kinked up in the bed, okay? Somebody left a clamp on it, okay?
Lung is reinflated.
Lung is reinflated or the tube is kinked, okay? And so, think about this in clinical practice. You come in, you look at the water seal, there's no titling, which by the way, that was the scenario in your sim. There was no titling in the water seal. It's hard to see because there was so much damn bubbling happening in there, which was also a problem, which we're gonna get to. But if you're looking and you see no titling in the water seal, that could be a good thing or a bad thing. The bad thing would be that the tube is kinked. And so you're gonna sit the patient up, you're gonna check the tubing, right, starting at the patient, moving down. You're gonna listen to lung sounds, you're gonna check and see how much output. If there's not been much output, the lungs are clear, the vital signs are good, and the patient's not laying on the tube, what do you think has happened? Good news, the lung has re-expanded, and then you can tell the provider, hey, I listened to his lungs, they sound great. I see no titling on the chest tube. He hasn't had any output out. You wanna get a chest x-ray and let's confirm lungs been re-expanded, we can get this tube out, okay? You're not gonna know that until you assess your patient, sit them up and move them. So if it were kinked or clamped, when you move your patient around, you're gonna see that. Oh, it was clamped, okay. And now, oh, there it goes again, it's titling again. It was just kinked or clamped, okay? Now, many of you wrote leak, okay? If there were a leak, what would be happening here?
The bubbling.
Bubbling.
That's the jacuzzi. That's the jacuzzi vibe. It's like bubbling.
No, we're not there yet.
Oh, really?
I mean, it might look like a I don't know, what is it? Just probably, it's probably not gonna be like that. It's probably gonna be, does it do it now? It's probably just gonna be bobbing up and down.
That part.
The water seal, we're still on the water seal, okay? So if in the water seal, you see bubbling, if it's bobbing up and down, okay? That means there's a leak, okay? And that is what you should have seen in the sim lab. In the water seal, it was just going nuts. It was just bobbing up and down, going crazy, okay? Because it was no longer connected to the tube that was in the patient. And so there was a leak. And so oftentimes this is where the connection is. This would be the tube coming out of the patient. This is where it connects. It's gonna be taped. It's gonna look rinky-dink. I'm just telling you. That's usually where it's leaking, okay? However, if you take the clamp and clamp it up here where it connects to the patient, the bubbling stops, problem's at the patient. If you move the clamp down to the canister and the bubbling stops, the problem's at the canister, okay? So bubbling in the water seal indicates a leak. No titling in the water seal indicates either a kink or negative pressure has been reestablished. You have to know this with your every fiber of your being, okay? You're gonna see the word kink, you're gonna see the word leak, you're gonna see the word bubble, you're gonna see the word tidal. You have to know where that should be and where that should not be, okay? In fact, for this test, I encourage you to read the question and cover the answers. Because I know how you are. If you see kinked, you're gonna say, oh, it's cute, we talked about a kink. Pick it. No, we talked about a kink when there's no titling. We didn't talk about a kink when there's bubbling, right? I'm serious, you have to know. This is not the test where you say, oh, I heard Lauren say, no, you have to lock in, you have to know. So as you're studying with each other, that's how you gotta ask the question. You walk in, you see, what do? No hesitation. You see no titling, what does that mean? If there's either a kink or negative pressure has been reestablished. You see bubbling in the water, so what does it mean? A leak. Check the connections. You know what I mean? Okay. The last column is the suction chamber. It is optional, okay? So all chest tubes will have the first two columns, the drainage and the water seal, okay? The suction chamber, here's my suction tubing, is gonna be hooked up to an outside source. In fact, it's hooked up to the same thing you guys are using to suction your endotracheal tubes, right? We only use this usually in the initial phase of putting a chest tube in to aggressively, actively pull the fluid and air out, okay? And so most of the time I see a chest tube, because I work in med-surg acute areas, they're on water seal. We're not even using the suction, because we've already sucked most of the stuff out. Now we're just kind of letting it passively drain, and we're working them off of this thing, okay? So when it's hooked up to suction, that's a vacuum to actively pull stuff out. It's optional, okay? It's definitely gonna be in place when the patient's more critical, when they're first admitted, that sort of thing. What controls the amount of suction is the water in the suction chamber. So you can see there's measurements alongside, 5, 10, 15, 20, etc. That's gonna be whatever the physician orders, okay? Of course, if it's a dry system, it's a dial, okay? The suction on the wall does not control the amount of suction of the chest tube. It is the facilitator. It is the vacuum source, okay? I don't know how this shit works, guys, okay? Some weird physics thing. I don't know what the barrier is between this and the device on the wall. I just know what controls the actual amount of suction is what's on here, okay? With that being said, as you dial up the suction on the wall, right, it's going to create bubbling in the suction chamber. Okay, in fact, if we took this to the lab right now, I could literally hook this up to suction and show you. You should see what kind of bubbling in the suction chamber. Just shout this out.
Like
Light bubbling, gentle bubbling. It should be like an aquarium, like Finding Nemo. Bubbles. Okay, not a jacuzzi, not. Why? Because if it's like that, the water is going to evaporate, and then you're not going to have enough water in your suction chamber to be within your orders to have enough suction. Does that make sense? So turning that up all the way doesn't change the amount of suction. It changes the amount of water that's going to be evaporated, and then it's going to change the amount of suction. Does that make sense? Okay, so the only bubbling that's happening anywhere is in the suction chamber. And it should be gentle bubbling like an aquarium. That's normal, that's fine, that's what we want to see. You have a question?
I just want to verify, so the wall suction is optional, and the patient's usually like critical. They can be hooked up just not to the wall, just straight water seal. I know I see like that before, and the water is controlled. Okay.
Yeah.
This is the first time I'm hearing this.
I very
Right.
rarely, in my experience, see this. Because my patients aren't that acute. These guys are usually in ICU. You're probably seeing them in ICU, okay? And then they're saying, hey, we're gonna transfer them out. They're going down a step down. We're gonna put them to water seal. This is literally what water seal means. I just took the suction away. That's it. In fact, if your patient is hooked up to continuous suction, one of the things on the PowerPoint, it talks about transportation. What if they gotta go to a CAT scan or an X-ray or whatever? Well, most of the time, you can just put them to water seal temporarily while they go down. If you've ever had a patient with an NG tube hooked to suction, it's the same shit. You just take them off, they go down, and guess what happens when you hook them back up? You get a shit ton of fluid back out, right? Because it hasn't been draining for that period of time while they've been gone. It's okay, it's all right. I've only had one time in my whole life where the doctor said they can never come off suction. And so they had like a little portable suction canister that went with their chest tube so they can continue to suction even while they were off the unit.
What was wrong with them?
I don't remember. Okay, so rare, it's, rare scenario, but most of the time they're going to transport, we're just gonna take the suction off, hang it with our cute little hangers on the transport bed, and they're gonna go down on water seal. So when I say water seal, it literally means the chest tube does not use the suction canister. A wet system means there's water in the suction chamber. A dry system means there's a dial. But what makes it water seal is if we're using suction or not. Okay, so if we're using suction, it's not considered a water seal system. It's a full-blown thing. So like a physician might say, put them to water seal. This is literally what he means. Take the suction away. Let's see what they drain passively without us forcefully sucking it out.
But that can still be with a dry system.
Mm-hmm. Yeah, it could be a drop, yeah. Well, really, because you're not using it.
And this is the part that you're like, I don't know how it works, but it just does, right?
Yeah,
Like
yeah, pretty much.
and we just accept it.
Yeah.
Yeah.
How this doesn't affect the amount of suction of this, I do not understand that. I perfectly understand the bubbling and how, I don't know. I just know what I know.
I think it's wild that you don't have to have the suction on that, but it will work.
Well, you don't have to have the suction on here, but it will still drain.
Yeah.
But it's not gonna pull
Because
it
of
out.
gravity, yeah.
Right.
Gravity will let it
We'll let it
dribble
drain.
out.
Right.
But when it's
But
not
this
dribbling
is
out
not-
by itself and it needs help or there's a lot of pressure, they're gonna pull it out. with the
Yeah.
vacuum.
That's right. That's right. Okay.
What do you
Now,
call it when you said put them on
water seal?
seal? And then what do you call when you put it back?
I don't
Put them
know.
on suction.
On suction.
Suction.
Put them in suction. Yeah.
Okay.
I've even seen you guys are probably, I don't know if you've seen this, but nasogastric tubes that are hooked up to decompression, sucking stuff out all the time.
Yeah.
Physicians will sometimes put them on a clamping trowel. So they'll say, take them off of suction for 4 hours and then hook them up and let's see how much it drains. So I could see them doing something like that with a chest tube. Like, let's take them off suction. Let's monitor the output for 4 hours. Hook them back up and see how much it drains when we pull it off. Like, how much are they actually collecting that would be drained if we hooked it up aggressively versus on its own. Okay, now, pretend this is the chest tube coming from the patient's body, okay? It's up here. If the patient, here's the chest tube, it should be connected like this. If this becomes disconnected and falls on the floor, what are you gonna do with this?
You want us to write it or yell?
Yes, write it. What are you gonna do with this tube that is sticking out of the patient's body?
Wait, can you say that again?
This has come disconnected. This is the chest tube, with the eyelet holes, yada, yada, yada. What are you gonna do with this? Yes. Good. Good, good, good. Just this. Not that yet. Good. Okay, this looks crazy, I know, but you're gonna submerge this tube in at least 1 inch of sterile water. Okay, 1 to 2 inches of sterile water. It's gonna look crazy, okay? You need like a glass sitting here, a cup sitting here, and that tube has to be submerged under the water. Why? Because if you have a cup and you blow into the straw, that air doesn't come back up the tube into your mouth, right? So if this air that is supposed to be coming out of the pleural space, we want it to continue to do that, and we don't want it to go back in, right? So we submerge it in water, we basically created a water seal. In fact, this is how this whole system was created, with glass bottles. If you watch Pearl Harbor, I'm talking about Josh Hartnett, Ben Affleck, she's pushing a cart with a bunch of glass bottles as all these victims come in. Why? Because they all got gunshot wounds and penetrating traumas, and they absolutely have, penetrating wounds where air is getting into their pleural space. Right? And so she's gonna put a chest tube in, well, somebody is, and then submerge the end of it into water and a glass bottle. All right, and then somebody smart came along and created this cool little device, but that's what it is. Okay, and then of course you get a new system and yada, yada, yada. Now, if you're a patient, here's their chest tube, has pulled it out of their body. There's no tube in their body, just an empty hole now. What do you do then? Yes. 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 Yes.
Okay, appreciate my art.
That's good. You're gonna place a dressing taped on 3 sides, okay? And the purpose of that is to allow air to escape, but when the patient breathes in, that dressing is gonna come down and it won't allow air into the pleural space. In fact, if you watch any of those like trauma shows, you know, talk about like sucking chest wounds, and every time the patient breathes in, more and more air gets into their pleural space. And so I've seen where they put like credit cards, you know, they'll tape a credit card down or a plastic bag, something so that when the patient inhales, that comes down over the hole, but when they exhale, it can blow out, okay? The whole purpose is that we don't want stuff to go back into that space, and we want to allow things to come out of that space, okay?
So if someone has a gunshot wound to their lung, I can just take my credit card on it and I'll be here.
If you're watching
Girl.
Trauma Life in the ER or something, maybe. I don't know. Yeah. And then, I lost my whole train of thought. Dressing taped on 3 sides. Okay, good. I got it back. So, if this happens to you, right? Okay, your patient has pulled their chest tube out, you know, and there they go. Your initial response, right, is to get that dressing on there. Okay, that has to be the go-to thing you do. If you bust out a stethoscope, I'm gonna wrap it around your neck again. Okay, you got to get the dressing on. I know normally on a test it's like assess, you know. Okay, sure, but like, what do we need to assess? The tube is out. Okay, and so you need to get a dressing on there immediately. Okay, and then assess and evaluate the situation. Okay, all right, like we get a new tube in, we call the doctor, assess the lungs. But if you don't put that dressing on there first,
On your test, if we don't put the dressing on it first, we're in trouble.
what do you think I'm talking about?
That's gonna be a what is your first priority when blah blah blah. I guarantee it.
One of the options will be also tape lung sounds, and one will be put.
Are you gonna do
No
first?
doubt.
Yeah, what are you gonna do first? And just think about it, guys. In real life, like on a test, it's so silly, but like in real life, would you be like, hey doc, he pulled the chest tube out, and then expect your doctor to walk in with this gaping hole that you haven't done anything about? No,
Call provider.
no. You better do something about it first, or I was just telling the morning group, I said, it's like a code. Could you imagine? Hang tight, sir. I'm gonna call and then get my stethoscope. No, you're gonna lay the head of bed down, you're gonna take the pillow out, you're gonna get started, and then you're gonna holler for help while you're doing all that, you know? You're gonna just hold on there a minute, just hang tight. And, okay, good. What time is it, y'all?
I have no idea. Almost
Okay.
40.
Okay. There are only a few times when you can clamp the chest tube. Tell me what those times are. And when I say clamp it, I mean for just a few seconds, you know, 10 to 20 seconds or so.
I'm guessing.
I mentioned one of them earlier. Yeah. That was the one I mentioned too.
I know one of them. It's the other.
Good. Good.
Sarah,
That's good.
I think you're gonna leave this with that
good.
stuff you complained about.
Oh, we were talking about that.
Yeah.
I know. I thought it was Oreos or black mold, and no.
Good. Good. The 3 real times that you would clamp it, yeah, are to check for leaks, when changing the system, or right before the doctor goes to remove the tube. Okay, we do not strip the tubing, we do not milk the tubing. Okay, that's like they used to. Dr. Lozier, who taught before me, he's like, oh, everybody should be just stripping them. I'm like, no. Okay, if there's like a clot in there or something, thank you. Just same way you would do with a Foley. You know, you try to facilitate it. If it's truly stuck, I'll be calling the doctor. We give thrombolytics through these sometimes. You know, so we'll come in and jam some, I don't know what, through there and try to bust up some clots. Okay, but we're not doing that. He would do that.
First thing I saw was a chest tube when I went to Children's. I was like,
Stripping it?
Mm-hmm.
Stripping it, sounds kind of fun. All right, okay, other things, just a little review here. I can't see any of the words, I just see the pictures. There's a whole slide on like nursing care, okay? And I know people get excited when there's a chest tube, okay? And it's like, ooh, you know. They have a chest tube. Okay, they gotta do all the stuff. Okay, they gotta cough, they gotta deep breathe, they gotta use their instant spirometer, they gotta get up, they gotta walk. Okay, the answer is never lay in bed and rot. It's not. They gotta get up, they gotta move. That's the only way those lungs are gonna get familiar with what they need to do. Okay, so as you're looking for answers or thinking about how to care for a patient with a chest tube, it is really no different than any other patient, and they're gonna be very intimidated by this. You know, and so you're gonna say, I'll carry it like a purse, Mr. Jones, and all you have to do is walk, okay? And I'll worry about this, and you worry about you, and we're gonna walk down the hall, okay? You're gonna use your internal spirometer. It's gonna be so cool. You're gonna watch this rise and fall, and some of her bees rise and falls, and it's gonna be a whole vibe, okay? But it's not, you know, Q2 turn. No, get them up, get them walking, get them moving, and you're gonna have to be their cheerleader to do that because they are not gonna want to. Look at this chest tube, look at this thing right here, it hurts so bad. Yeah, they're not gonna be on your program. Does anybody have their PowerPoint by chance?
I do.
So I can see if I'm missing anything?
Is the 3-bottle system gonna be?
Yeah, that's all it says.
What?
The 3-bottle system.
Guys, this is a 3-bottle system.
But I mean like the old back. Cause it was a little different.
It's not. Collection,
It's
water
just in
seal,
different order.
suction. That's why I told you don't worry about those, letters.
It's a little different.
What are you doing back there?
Fine for my life. We were up till what? When did we go to bed, guys? 1 a.m. Roughly.
Look,
Wait, what?
Our project.
You guys were all together doing
trap,
that too?
water seal, suction.
You were asleep.
And what I had to talk to, was it she said these letters go into
I worked on it all day, so we better not.
Oh, no.
Yeah.
We're good.
Yeah. I got up at 7 and literally worked on it until we went to class yesterday.
Sorry.
I wanted to make sure it was good.
I didn't understand that. So I was like, why is it so basic?
Okay, your PowerPoint does say turn back to side every 2 hours. Okay, that's for your patient who like is truly not safe to get out of bed. Okay, if it's safe to get them up physically, get them up. And her notes even say get out of bed ASAP, so she knew what was up.
Need a wrap.
Okay, of course, we were talking about it, but you know that this chest tube would never be sitting here. It needs to be below the level of the patient's chest or sitting on the floor. That's why it's got a cute little kickstand. Okay, she probably had a little AI develop this for her at the end, but this is what I'm talking about, y'all, right here. What do you do if the drainage system is knocked over? You're gonna set it up. You're gonna make sure all the levels are where they're supposed to be. So for me, I would have to put more water in the suction chamber because it was at -20. When I kicked it over, it spelled, and there's too much water in the water seal. Okay, so first you're gonna check it, make sure all the levels are where they need to be. If they're not, then you have to get a new system. What do you do if your patient's going to radiology or a CAT scan with a chest tube?
Drained by gravity.
Good, put them to water seal, take them off of suction, so long as the provider says it's okay, 9 times out of 10 they're gonna say that's fine. What do you do if you see bubbling in the water seal?
Check for a leak.
Check for a leak, did you hear it? Not a kink, a leak. Okay. What do you do if the chest tube accidentally gets pulled out from the insertion site?
Okay,
What's the three-way?
The
turn
3, yeah.
Dressed and taped on 3 sides. What do you do, if the chest tube disconnects, if the chest tube tubing disconnects from the chest tube?
The sterile water.
Good. What do you do if you see a constant fluctuation in the water seal? It's called titling.
Oh, that's good. We want that.
What do you do if you see no titling in the water seal?
Check
Check
for
for kinks.
kinks or
the
assess
lungs.
the patient for reinflation of lungs.
Very good. How do you know when the tube is ready to be removed?
They have
Clear
no
No
output,
drainage.
No output, clear lungs,
stable vitals.
stable vitals, love that. And it will be solidified with what diagnostic test?
X-ray.
All right.
Those were the questions at the end of the PowerPoint. They have
Oh, were they?
problem solving thing.
They were good. Okay, and that's how y'all should study. What should happen here?
A point? Did you make it out?
Yeah, but her document looks like
Oh,
AI.
I like to do my notes on the PowerPoints, but sometimes the backgrounds are so dark that I like have to go and edit them, and I also combine some of the slides because,
It's too
there's a
much.
lot of them.
There's one more thing I was gonna say, hold on a second. Okay, that's how you should study problem-based scenarios with the chest tube and what you would do about it. And then I would be able to talk about this like I can, okay? So I would pull up a picture to your loved one and say, let me just tell you about this chest tube. Okay? This is the collection chamber, and if there's more than 100 milliliters per hour in here, bright red blood or clots, we would call the doctor. Okay, this is the water seal. There should be 2 centimeters of water in here. We should see titling. If we don't see titling, that means that the tube is either kinked or negative pressure has been reestablished, and I would know that because I would listen to lungs, check vitals, and we'd confirm with an x-ray. Yes.
100 milliliters an hour of anything or 100 milliliters of blood?
100 milliliters per hour of anything.
Of anything?
Yep.
And
Okay, and then you would go over to the suction chamber and you would say, it's kind of freaky, but what controls the amount of suction in the suction chamber is the amount of water pressure. But we use an external source that's connected up here to facilitate that. We should see gentle bubbling in here. If we see jacuzzi type bubbling, the suction's up too high, we've got to turn it down. And that would be problematic because it would evaporate all the water and then we would not be within the physician's orders. If I were to see bubbling in the water seal, I should not see that. That should only be happening in the suction chamber. If I see bubbling in the water seal, that means there's a leak. And I would know by checking closest to my patient first. Could even clamp it temporarily, see if the bubbling stops. If it doesn't, move the clamp closer to the chest tube device. And if it stops, then the problem is at the chest tube. Fix my connections, and if the bubbling stops, then I know that that's the problem.
So in the PowerPoint, it says the settings are -10 to -20. Is that just the dial or is that the water
Either
as
one.
well? Okay.
Either one. So in this system, it looks like this, but in the other system, it's a dial with -10, -20, and so on and so forth.
Okay.
Okay? So no one will ever tell you, as far as I know, what to do with that thing on the wall. You only know by what kind of bubbling you see. And then for the dry system, they probably didn't show this to you in the lab, but on the dry system, there was what we call a bellow. It's like a little orange, it looks like a pillow, a little accordion thing, and you would have to turn that suction up enough to see that pillow pop out.
yeah, no one said that.
Yeah.
Is
It's
that
okay.
what it
No,
says? Okay.
it's okay, but that's how you know. So like, when I was down there, I said, watch this, and then it was like, a little pillow popped out, and we were so excited. Okay.
Are there gonna be questions about the dry one?
I don't know,
Is there questions about the three bottles?
if you guys can have one more time.
About the what?
They're all the three.
Oh.
she
They're all
said.
the 3 bullets.
I think the slide is just showing, kind of trying to separate them into different parts, but that's not how it like necessarily looks for us.
Right.
It's
So
just
like the 3 bottle system is literally this. This is just now one cute little device because who's gonna be in 2026 pushing around a cart with 3 bottles on it, you know, and then they
Yeah, it's
spill
not
and.
hers.
Yeah, now it's a purse. And then someone even smarter came along and said, let's get the water out of the suction and make a dial, you know, so we just continue to improve it. And that's great, but I do think you will still see wet systems, which is why I'm going to test you on it, because I need to know that you know how to use, you know, the old school stuff. Same thing with the 3 bottle stuff, like if you can understand what's happening in the 3 bottles, you understand all of them, that's all of them, yes.
For, the airways, the different ones.
Yeah.
I had written like, to decide what type of tube to use to determine, but I hadn't written down like what, and I was wondering, is it the patient's like consciousness, and then why they can't breathe? Like
Yeah.
where is it?
Yeah. Yeah, I think that's good. Definitely what kind of patient to put it in, how to measure, and how to insert it. Would be the best. What those guys say in the video is good. It's short and sweet, little bullet points. You know, invert, insert, rotate, locate, remove, remeasure, reinsert. It's cute. I like cute, you know. Okay, that's what I got. Oh, one last thing I want to say. I've said this to my current evening group numerous times, but there are going to be a lot of announcements coming about course surveys, okay? And I hear from you guys verbally all the time, and I appreciate it, and I love that you're so candid with me. But it is one thing for me to take what you say to me verbally and communicate that. It's another when I have data, when I have numbers,